Thank you so much, Claire. I really appreciate the opportunity to speak with a great audience today. The attendance looks wonderful. So,
yes, thank you. I should just add that the Q&A will run as before. So I'm going to hand over to you now, Dr. Owens, and join you in 30 minutes with some questions.
Sounds great. So what I'm going to be presenting on this afternoon is a little bit of a different topic because I think we tend to think a lot about pharmacologic interventions for narcolepsy. But what I'm going to focus on today is on behavioral strategies, which I think can also be extremely helpful for patients and families. And I'm going to really hone in on the pediatric population, which is the one that I largely treat. I do have some disclosures, none of which have bearing on what I'm going to be discussing. So what I'll talk about is potential behavioral treatment targets in patients with narcolepsy, as well as the evidence, and in some areas it's better than others, that support behavioral treatment strategies to improve the lives of patients with narcolepsy. And then also to talk about potential approaches in incorporating those behavioral interventions in treatment plans for these patients, and again, with an emphasis on the pediatric population. So just to talk a little bit more broadly, the consequences of hypersomnia disorders, which I certainly don't have to describe in detail to this audience, specifically in adults, involve having more educational and behavioral problems, higher rates of depression and anxiety, occupational challenges, more prone to driving accidents compared to healthy subjects in both treated and untreated subjects from the drug perspective. Conversely, though, the risk of car accidents in patients treated for at least 5 years was not different compared to healthy subjects. So there's a little bit of a ray of hope in looking at these issues regarding safety. So in talking about impairments related specifically to excessive daytime sleepiness, with this inability to stay awake and alert during major waking episodes of the day, with periods of irrepressible need for sleep or unintended lapses into drowsiness, can be confused with fatigue, particularly at the initial presentation. But while fatigue presents with a lack of energy without inadvertent or excessive sleep, sleepiness implies an increased propensity to fall asleep. Not always easy to make that distinction. In our society, there is a negative perception of sleepiness and an increased need for sleep. And there are certain individuals, prominent individuals, who brag about getting very little sleep as a badge of honor. But the goal of treatment is to produce the fullest possible return of normal function for patients at work, at school, at home, and socially. And pharmacologic treatments are considered first line, but there are a number of limitations to the effectiveness. And I'm going to talk a little bit more about those in detail as we go along. Cataplexy, of course, as we know, is defined as episodes of sudden transient loss of voluntary muscle tone, triggered by strong emotions in many cases. And so patients may be able to sense the onset of an episode that allows them to avoid injury or reduce the risk of injury, but still those injuries do occur in a substantial percentage of patients. And many patients have several episodes of cataplexy per week. In children, this is a very different story in that cataplexy or motor movement, abnormal motor movements, may be characterized by gait disturbances or falls, and hypotonia with prominent facial involvement, which we term cataplectic facies. That includes eye drooping, mask-like faces with slackening of the jaw, facial grimaces, and oftentimes tongue movements or protrusion of the tongue. And again, pharmacologic treatment is considered first line for cataplexy, but there continue to be significant limitations to the effectiveness. In addition, there are clinical features of sleep paralysis, transient voluntary muscle movement inhibition, with the inability to move most parts of the body or speak during the episodes that may be accompanied by very frightening sensations and may need vigorous arousal in attempts to resolve, and may be triggered by stress and insufficient sleep. The hypnopompic and hypnagogic hallucinations can be visual, auditory, tactile, or multisensory. And some of the descriptions include that of an intruder sense or a presence in the room, an incubus or a pressure on the chest resulting in breathing difficulties, and even unusual bodily experiences such as a floating sensation or feeling like an out-of-body experience. And again, this may be exacerbated by stress, perhaps by position. Some evidence that reading in bed may exacerbate this. And do we know whether there's any ability to actually manipulate the content of these hallucinations in order to make them less frightening and anxiety producing? So when we look specifically at children, children and adolescents with narcolepsy are at greater risk for attention and cognitive dysfunction that impairs their academic performance and may impact negatively on school attendance as well. Poor social functioning. It's estimated that some 2/3 of children with narcolepsy experience significant social difficulties, and they may be less likely to participate in leisure activities or sports-related activities, potentially because of concerns about triggering cataplexy. Disturbed mood. Again, almost half of pediatric narcolepsy patients report emotional problems, and some 25% up to may endorse clinically elevated depression symptoms. In addition, young patients are more likely to experience physical comorbidities, including other sleep disorders such as insomnia and sleep-disordered breathing, precocious puberty, early onset of puberty, and obesity that can further exacerbate the psychosocial challenges that these children face. And the overall toll of narcolepsy in the pediatric population is quite clear when comparing health-related quality of life with age-matched controls, and children with narcolepsy suffer across every aspect of their quality of life, physical, psychological, and social. And parents also struggle with this, very much so. So a recent study showed that 100% of parents of children with narcolepsy who were surveyed were very concerned about how their child would cope with their disorder, and 2/3 were anxious about practicalities such as how to afford the medical costs associated with treatment. And caregivers really wanted a forum, an outlet for sharing information and their own experiences, and the ability to provide and also receive encouragement for coping in everyday life on a both informal basis and in professionally led peer support groups. However, the parents who were surveyed stated that many of these expectations were not being met, especially those concerning information about needed services, financial benefits, availability of local support, and that's where, of course, an organization like Wake Up Narcolepsy becomes so critical to the quality of life and reducing the stress of caregivers for these patients. So some additional features that are relatively unique to the pediatric population in that many children, there is an abrupt onset, a very sudden onset of core symptoms, including cataplexy, excessive daytime sleepiness, hallucinations, obesity, etc. And it's very important to frame this for both patients and their families. This represents a sudden loss of a previous condition of health and well-being. And this is a lifelong neurological disorder that has no cure. And that conversation when a child is diagnosed with narcolepsy is one that is very difficult, but extremely important to have. And it's an ongoing dialogue with families and patients. And thus, there's this need for the child to understand that being sleepy, which they may have been made fun of or bullied about, is symptomatic of a chronic disease that's going to affect them for the rest of their life and require daily management. So it's really a devastating message for many families. Their level of adaptation never ceases to astonish me, and I don't want to sound gloom and doom, but I think it is important to recognize that this is a huge event in families' lives. So I wanted to talk a little bit about some specific patients, and these are actually short cases of my own. This was a 17-year-old girl who was diagnosed with narcolepsy and cataplexy at age 13, following an HPV vaccine. She previously had been treated with a regimen of medications in Europe. She was a very high achiever, as many of these adolescents are. She was currently on armodafinil and sodium oxybate. She asked about alcohol and sodium oxybate because having spent the last several years in Europe, having wine with dinner was a very normal thing for her family, even at her age. She was also planning to become sexually active, and she was applying to college and was wondering about logistics of medication in terms of sodium oxybate. So we do know officially that alcohol is contraindicated in patients who are using sodium oxybate, and the recommendation is for complete abstinence in any patient who's being actively treated. And there's no specific amount of time after administration in which alcohol is deemed to be given safely. In addition, patients on modafinil are also cautioned to avoid drinking alcohol because it's not known how this will affect. So this is a very difficult conversation to have with an adolescent, and something that we may need to negotiate about in terms of the best possible safety use of alcohol in a patient who's almost certainly going to use it anyway. And you want them to be able to share those concerns and have a transparent dialogue about this. This is another patient who was a 21-year-old female who had been diagnosed with narcolepsy and cataplexy 6 months before and was started on armodafinil. She had been unable to attend school or work prior to starting medication. And when we increased the dose, we discussed the reduced efficacy of oral contraceptives with armodafinil. She described severe cataplexy, so we also added sodium oxybate. When we had this conversation about sexual activity and using a barrier method on oral contraceptives, her mom, who had accompanied the patient to the visit, said, "This isn't going to happen on my watch." Well, unfortunately, a month later, a pregnancy was confirmed in this patient. And it was unclear, at least initially, how far along in the pregnancy she was. So this is another difficult conversation to have, because we know that hormonal birth control methods may not work while taking modafinil. And there, in this particular case, there was also the challenges of a pregnancy. And this is a patient who had had severe cataplexy before starting sodium oxybate, and kind of working around those issues. And also addressing the relationship between the mother and daughter in regards to what mothers saw as a violation of trust in terms of her moving forward with being sexually active, despite her age. This is another patient who is a 17-year-old high school senior diagnosed with narcolepsy and cataplexy. She was on oros, methylphenidate, and sodium oxybate, but wasn't really compliant in taking the second dose. She had significant daytime sleepiness, profound sleep inertia after scheduled naps. She was hoping to get her driver's license despite this significant daytime sleepiness. I'm sorry, and this was a male. So he was applying to college and wanted to be a pro football player, but had already sustained 2 concussions. Well, the NCAA bans performance-enhancing drugs, i.e. stimulants, to protect student athlete health and safety and ensure a level playing field. So that's one challenge. For the student athlete to be granted a medical exception for the use of these substances, they must have declared the use to his or her athletics administrator, present documentation of the diagnosis of the condition, and provide documentation from the prescribing physician. So among many other challenges to the student athlete, being on stimulants or prohibited medications can be an additional one. This next case was a 13-year-old freshman in high school with a 6-month history of excessive daytime sleepiness. She had been already diagnosed with depression and started on fluoxetine. Her MSLT off medication was not conclusive. She was started on a trial of stimulants but had multiple side effects. She was then falling asleep around 11 p.m. because of her homework burden and needed to get up at 5:30 because her school started at a very early hour. And her special ed services were dependent on having a formal diagnosis, but we didn't have an absolutely conclusive set of diagnostic testing. So in terms of educational issues, schools in general desperately need education about hypersomnia disorders, but there are confidentiality issues and, of course, social stigma associated with those. Eligibility for special education services is absolutely critical. Either a 504 accommodation plan, or more likely an IEP, individualized educational plan, which might include issues like timing of taking tests, timing during the day, or having extra time on tests, reduce homework assignments, etc. Building in nap opportunities to the student's day, which is very, very challenging in many school settings. Chronic sleep loss and excessive daytime sleepiness occurs in healthy students without narcolepsy. Chronic sleep deprivation is a public health issue in our country and in many countries around the world. And this is an additional burden to students who already have excessive daytime sleepiness as a result of their narcolepsy. And so, this gets to the issue of middle and high school start times earlier than 8:30, which have been shown pretty definitively to have a negative impact on sleep and alertness during the day. And also the whole transition to college in terms of choosing a college, career counseling, preparation for college, including the issue of taking medications once the student is, especially if they're living at school. This is another case of an 18-year-old college freshman diagnosed with narcolepsy and cataplexy, had failed multiple medication trials, and as a result was refusing to take any medication, but had obtained a driver's license while he was taking his medications and wanted to continue to drive. He stated his excessive daytime sleepiness was quote unquote under control, even off medications. He denied cataplexy, but objectively his mean sleep latency was 6 minutes, and he had Xyrems on 3 out of 5 naps. So that is a very challenging situation in terms of helping the patient to make good decisions about their safety and the safety of others while driving. So what about some solutions here? So sleep manipulation. We know to a certain extent that extending nocturnal sleep can result in significantly prolonged sleep onset latency on an MSLT, so it seems to improve sleepiness. There's some evidence that long naps are beneficial in reducing performance impairments in patients with narcolepsy. But that's certainly there's really relatively little evidence about this. Another study showed that a 1-month program of regular naps improved sleep onset latency, but another study in comparison showed that short naps, so 15 to 30 minutes, improved sleep onset latency. And the addition, in this final study, addition of 2 15-minute naps did not alter symptom severity or unscheduled daytime sleep. So what we don't know is what is the optimal length, timing, number, and frequency of naps, and particularly in the pediatric population, does this change with age? What is the combined impact of extended nighttime sleeps plus naps, the combined impact of medication and sleepiness manipulation, and the differential impact of naps on a variety of outcomes. So are naps more beneficial for cognitive function? Do they have a differential effect on mood regulation? And the whole role of sleep inertia, which is particularly problematic in patients with idiopathic hypersomnia, also may change the beneficial effect of naps in general. Nutrition and exercise, we really know very little about the impact on narcolepsy. We do know that patients with narcolepsy tend to eat more frequently, that they, but most of these studies have been in animal models and have suggested that animals with manipulation of knockout mice, for example, are less likely to run on a wheel, for example, to get less exercise. But we don't know the impact of timing, frequency, caloric composition or food composition on daytime sleepiness and performance. The efficacy of interventions to reduce weight gain in children with narcolepsy. We do oftentimes refer these patients to a weight modification program, but we really don't know very much at all about how efficacious these are in the setting of narcolepsy. The impact of different intensity, duration, frequency, timing, type of physical activity on daytime sleepiness and performance, as well as on cataplexy. In terms of cognitive behavioral therapy, there is some evidence to suggest that hypnosis, for example, can These are case studies, can reduce sleep attacks and sleep paralysis. One case study that I could identify showed that lucid dreaming improved sleep paralysis, hallucinations. Muscle relaxation, again, these are all single case reports, reducing sleep attacks. But there is some mounting evidence to suggest that cognitive behavioral therapy can improve better drug adherence through the mechanism of improved problem solving, using circadian factors to schedule activities when patients are most likely to be alert, and also helping patients to attain better psychosocial adjustment. So all of those can be components of cognitive behavioral therapy. We don't have any, to my knowledge, randomized controlled trials of relaxation or hypnosis impact on a variety of different parameters, symptomatic parameters, or the impact of other strategies, complementary and alternative medicines. And there's little evidence one way or the other to support the efficacy of support groups, although obviously patients want those, and our definite bias is that these are very helpful to families, but it would be really good to look at what types of support groups are most effective. In terms of driving strategies, this is really interesting because I actually polled a number of my pediatric sleep colleagues around the country several years ago in terms of how they determine whether an adolescent is fit to drive. In some studies, pathological sleep latencies on the maintenance of wakefulness test predicts driving impairments. And in another study, a majority of sleep specialists indicated that untreated patients with narcolepsy should not drive. But the majority also felt that driving should be allowed after quote unquote successful treatment, but how exactly do you measure that? And so we don't know the best standard of fitness for driving, particularly in the adolescent population where inexperienced drivers oftentimes maybe have an increased risk-taking behavior. And what is the role of cataplexy on top of the issue of excessive daytime sleepiness? And what are optimal strategies for young drivers? And I think this is an incredibly important area that deserves a lot more attention. So some of us have embraced what can be called CBTN, or cognitive behavioral therapy for narcolepsy, which is envisioned as a comprehensive multi-component cognitive behavioral therapy program for both narcolepsy patients and their families to improve self-efficacy in managing their symptoms, enhance their overall quality of life, and reduce disease burden. And it includes psychoeducation of patients and caregivers on the characteristics of narcolepsy to improve knowledge and awareness and decatastrophize the experience as much as possible. Combined educational and behavioral management interventions, including self-monitoring, goal setting, reinforcement for healthy sleep behavior, linking medication, for example, to established routines so that adherence improves. Behavioral techniques to improve nocturnal sleep and daytime alertness, again, as scheduled naps, and that's why we need so much to know more about what works best in terms of timing and duration, etc. And things like nocturnal sleep consolidation, whether dietary or physical activity changes might be helpful for patients, and relaxation strategies to better effectively manage cataplexy. Other components might include documenting and developing behavioral adaptations to reduce hallucinations and fears of being alone, cognitive restructuring around maladaptive cognitions associated with narcolepsy. For example, a child who refuses to go to a friend's birthday party because they are concerned that they're going to be made to laugh and have a cataplexy episode in front of their friends. And I've heard many patients, pediatric patients, avoid situations in which they will be told a joke or kind of spurred on by their peers to laugh, which is such a sad situation, especially for a child. Mindfulness-based strategies, assisting patients with the development of age-appropriate social skills that will help them to integrate treatment strategies into their day-to-day interactions with peers and also with family members, and development of coping skills that facilitate, and this is really important, successful completion of developmentally appropriate tasks, such as driving a car, transitioning to independent living, and negotiating the college environment. So goals would be increased understanding of and insight into living with narcolepsy, better medication adherence, coping, reduction of distress, maintenance of gains, and prevention of relapse of increased psychosocial burden, and improved quality of life, of course. And some of the challenges in instituting these kinds of programs maybe lack of public and healthcare provider awareness, but probably more importantly, the lack of sufficient numbers of trained providers who are specialists in behavioral sleep medicine, for example, who are largely concentrated in urban areas and around academic medical centers. Insurance may not cover these kinds of behavioral visits, management, but you know, when practitioners are surveyed, many of them were in favor of using behavioral strategies to reduce cataplexy, sleep attacks, excessive daytime sleepiness. And a substantial percentage of psychologists who are trained in CBT for insomnia are also interested in applying it to narcolepsy. And so around the world, there's a great deal of interest in these additional strategies and making sure that behavioral sleep medicine providers, for example, have training and experience in dealing with patients with narcolepsy. So we want to strengthen children's social skills and play skills, provide situations where they're less at risk to fall asleep, engage children in activities or games where he or she could be alert instead of sleepy and bored, promote use of self-controlled strategies, including how to interact with peers when misunderstood or made the butt of jokes or even bullied, to recognize sleepiness and tiredness in oneself and others, and decrease their negative cognitive attributions, especially when it comes to dealing with peers. So I would say in regards to behavioral interventions for hypersomnia, we certainly have a knowledge gap, and it may even be framed a knowledge chasm, but we desperately need more research targeting these specific behavioral interventions for both adults and children. But despite the relative lack of evidence, I think there are a number of, quote, common sense behavioral strategies such as planned napping, in general healthy sleep habits, good coping strategies, social skills that should be part of every patient's treatment plan. And I'm indebted to some of my colleagues, both here at Boston Children's and in my previous position at Children's National Medical Center, for their advice and wisdom in creating this presentation. So thank you.
Thank you, Dr. Owens. That was extremely informative. So much packed in there, and I learned quite a lot, and some other things I'd forgotten about that are relevant to our situation at home with Matilda, who's now 14. But we do have some questions for you. We've got about 5 minutes, so I'm going to combine two actually that talk about the HPV vaccine. I read about a few people getting narcolepsy from an adjuvant added to flu vaccine. That was pandemics in Europe. However, I haven't heard about HPV. The other person had. This question says, has the vaccine been modified? Are there new steps for approving vaccines if it is a vector for narcolepsy?
Well, I'm certainly far from being an expert on this, to my knowledge, particularly in China, there was evidence of at least an association between the onset of narcolepsy symptoms and both the HPV vaccine in some cases, but as far as I know, this has not been well established, certainly not nearly to the degree as the H1N1. This brings up an interesting question, and I was actually asked by one of my patients' families a couple of weeks ago, what about COVID-19?
Yeah.
I'm not aware of any cases of narcolepsy linked to infection, but there certainly are neurological symptoms that are clearly associated with COVID-19. And of course, the impending vaccine for lots of reasons, but that being one of the reasons, this family was very concerned because in-person school was about to start for their son, who's 11 years old and has severe cataplexy. And they were very concerned about whether an increased risk of exposure to COVID-19 could exacerbate symptoms. So that's sort of a separate question with regards to triggering onset of symptoms, but I think it's a legitimate question that I imagine many of my colleagues are also being asked in the context of clinical encounters.
What would you recommend that people affected by narcolepsy ask when, for their other family members who may not have the condition, thinking about the COVID vaccine? What are the questions we should be asking our healthcare providers before we consent to having a COVID vaccine?
Well, I do think, and hopefully we are going about this in a very cautious and conservative way, despite political pressures to kind of move forward with a vaccine very quickly. And that one of the things that will be monitored will be neurological symptoms, including excessive daytime sleepiness. I don't know whether that's something that is on the radar screen during these vaccine trials, but hopefully it will be. And we certainly don't want this to be a deterrent, this concern or fear or perhaps unwarranted anxiety about this to deter people from getting a vaccine that it will be important for so many public health reasons. I do think that viewing narcolepsy as a chronic neurological disorder, and so trying to mitigate the risk of infection in general is a good idea, but we don't really have clear parameters. What's my advice to a family that says, should I send my 11-year-old son to school, or should I insist on continuing remote learning? So, you know, these are thorny questions that we don't have the answer to, but we need to try to work with families as best we can and continue to monitor the situation.
Thank you. Have you heard of narcolepsy causing a reduction in the expression and overall range of emotions? And if so, what can be done?
Well, so as I mentioned, I do think there are patients who avoid situations that are likely to result in an emotional response, and because of their concerns about cataplexy. I think obviously if there are pharmacologic means to reduce the frequency and severity of the cataplectic episodes, that would be very helpful in reducing some of that anxiety and allowing a greater range of experiences and activities for children. The patient that I just mentioned plays football, and he invariably has a cataplexy attack when sitting on the bench with his friends, kind of horsing around. And you know, that has been very difficult for him. I think, you know, kind of trying to develop a reasonable balance between avoiding triggers altogether, which may really constrict patients' lives considerably. But, you know, trying to pinpoint specific instances or situations which are more or less likely to trigger cataplexy in conjunction with adequate medication management.
Thank you. We have lots more questions, and as I say, it was so packed and informative, but I'm afraid we are probably needing to move on to Danielle. But I'd like to thank you, Dr. Owens, for your service to the community and for taking the time to spend with us today. Thank you very much.
My pleasure.